For most people in Ntoroko district of the Rwenzori region in western Uganda, accessing health service is more of a myth than a reality. 4 years since it was granted district status, split from the mother district, Bundibugyo. Like any other newly created district in the country, the justification for the split was to bring services closer to the people. However, this justification remains a myth in Ntoroko, where the health service is marred by inadequate health facilities, shortage of health workers and drugs. The district has a population of at least 100,000 people, but there is 1 health center 4, 2 health center 3s, and 2 health center 2s, contrary to the government's health policy, which provides that every county must have a health center 3 with about 18 staff, led by a senior clinical officer with OPD and maternity ward and a functioning laboratory. Mulango is one of the 5 islands in Kanara sub-county on the shores of Lake Albert, where there is no health facility, putting the lives of more than 3,000 residents at risk. Residents are forced to use facilities at Ntoroko Health Center 3 or Rwenzori Health Center 3. The means of transport to the health facilities is by use of a boat, which costs 100,000 Ugandan shillings for a 2-hour boat ride. At the island, you see a big number of seemingly busy and excited people of all age, men, women and children, and a minimum of 100 small reed-made houses where they live and operate small bars and shops. The houses are just 3 to 4 meters from the lake where the boats are parked after the day's transport and fishing. Joe Zille, who has lived at the island for 6 years, describes the situation as appalling. He says it's difficult to take a pregnant woman to Ntoroko Health Center 3.
Hapa tuna wanawake, tuna pia na watoto. Kama tuna watoto, tuna wanawake wanazaa, wako na mimba. So unakutana mtu bibi kama ataka kuzaa, inakuwa problem kumtoa hapa kufikisha Ntoroko ama Katanga. Na tena kutoka hapa kufika Katanga kama kuna hii machine hizi wanafanyisha kwa engine kwa boti hizi, ama yake inakuwa problem kwetu. Kwani sisi tunashaka wanasema kama first aid, kwa sisi hapa first aid hatuna. Kwa first aid yako tu ni kukufa. Na kwa hivi muone namna mtatusaidia, kwa nini tunapata hapa hata ka hospital kidogo kwa kutusaidia. Tuwe Health Center tukue tunapata hapo nini? Madawa. Tena situation ni mbaya, sio nzuri, inafaa kuona namna ya kutusaidia. Toka hapa kufika kwa Center Katanga unaweza saa 4 kwa maji, kama unaenda unaweza saa 4. Rafre unapaswa kuwa nafasi kama mtaro 10.
Cyo kubanze kitwina hane kizibu kya amani. Twine kizibu kya kolera hano ne tukwata kubi muno. Kolera hano abasajja ne bafwa na abakazi no bwana bona amaizi busaho. Twine hano oburwire obubakweta blood resource. Hano bojo baronge bange singato muzurora zifuire silibu. Hano abantu tubakupima obupira bakondo mu busaho nabi bizibu bindi binyakuro hano nabirwaro nacho nicho kimu tulukubi twino mulingo mbazi tufunaho otaina sente no sono kufu.
The lack of adequate health facilities and workers has opened room for the operations of the village health teams in Ntoroko. Village health teams, the equivalent of a low-level health center, are meant to serve as the primary village-level health contact for all villages in Uganda. Mumbere Natkunda, a village health team member, set up a makeshift house that works as a health facility. However, it lacks the standard of the least functional health facility. There are no drugs. Women deliver on the floor by the help of the village health team member.
Na wetu mulango twine bizubu ntwende mbazi ntwendo buyambi habokuba hatwina abantu binje bakutura bakaza binje bacira kuzara bakaho kwizaho bumuntu batina nanka buyambi bona nonjerezeho kwamba kakantu akati tuyamba government tusindikira abasahabani bize batuyambe umanyuga abakaza binda bareke kuna manu babona enzo jyo nagisetting kajimazere onkandiyo nindenje sa kujiboneza nyanda na government erengo kunyamba kugira ngo enzogi nagimarira kandi yafune emibazi nayamba abantu bona abakazi abandi abakugira abandi nibazara tinkubasa mbambasindikira rero konka bingi abandi nibazara no muhanda.
At Ntoroko Health Center 3, which serves a population of at least 12,000 people, there is only one clinical officer who at the same time is the in-charge. The maternity ward is also a general ward where all patients ranging from children, women and men are admitted.
This health unit is, as you can see the clients that's outside, it's a health unit that serves people from different districts. People from even Congo, people from Kebale, and it being to Lake Albert, to almost one of the landing sites of this lake. There are many landing sites that even have people which gets here for a service. Kapkanga, Mulango, there are many landing sites. It has only one who is not yet even a senior, who is me, and at the same time an in charge. You find I'm being overwhelmed, handling administration, handling clinical, the ward where we get to admit clients. It's one ward, not nice looking, not smart, not, it needs renovation. And having this newly born with the mother taken into a general ward would have admitted a medical case, maybe it's HIV, maybe it's TB, maybe it's surgical case. It's challengeful. Then when you get cases of referral, our ambulance that we have, it's for those who can afford fuel. Having it fueled to Fort Portal and come back. But the area I'm working now in, people are poor. They don't have the capacity to even fuel the ambulance. How I wish if in between them there was another health center. It's very big, so it puts it to a great burden. And the clients themselves moving the distances. Come getting admitted in this multi-purpose ward.
Simon also says the rate of HIV/AIDS here is high. They receive 30 newly HIV positive cases per month, yet there is no CD4 count machine. Blood samples are instead sent to Fort Portal Regional Referral Hospital, where the patients have to wait for more than 2 months to know their CD4 results.
Statically, like here at the facility, if an outreach is not done, because we don't do it regularly, we get 30 clients turn positive in a month. So that's the big number. Newly confirmed that they are HIV positive. But these are newly who tells you, I have never been tested for HIV. We use districts that have CD4, that PIMA machine, that photo, Bundibugyo. So it puts, like, we get to receive like the results back. 2 attempts it can get to a month. This is someone who is poor. This is someone who has come from a very long distance. You tell him, now you have come, I managed to get the CD4 sample. Come after 2 weeks. Fortunately, it all comes and the results are not yet here. Goes back. May end up even getting lost or dropped, or I can't tell. So it demoralizes. Because this is the center for HIV. Many people here have HIV, and many people get to come from very many areas. So let it be equipped, though being looked at as a health center 3, let what is in need be of a great coverage, be able to offer many services at spot. If it is HIV, determination of CD4, there it can be done, not going to Fort Portal. If maybe there's need for an emergency, fuel will be there. We have and have the case taken. If it is maternity, let a ward be put different from this, and this one recommends specifically for newborns and postnatal mothers, and maybe antenatal. So that, and let it be in a good health status, smart, clean, and fully renovated. Those things. If it is an incinerator, I have seen incinerators which have chimney, which even if be hot weather, that can still be easier for the health worker or for the facility to have its waste decomposed. If it was things of staffing, let the cadres, the correct cadres, be put at the facility. So that when I'm not present, those who steal that will have remained offers according to the client's expectations. Not saying how I wish if I have found so and so. No, we're all the same, we are all here to offer service. So, if I were two, or if we had a nursing officer present in my absence, a gap couldn't be felt. The community couldn't make an alarm. How we wish we could have maybe have got an injection, but which injection would have prescribed so? He's a nurse also, because of what he was taught. Makes a gap felt by the client. So let those people, the correct cadres, be filled up. It is what nationally is expected, that a health center should have 2 clinical officers, a nursing officer, and 2 midwives who are essentials, and a lab technician if you have a lab assistant who is 1. And if he's not present, there are things that are unavoidable. Someone can fall, someone can get an emergency call, someone can maybe go for be invited. The lab tends to get closed. But if there were 2, meaning can be working shifts. Why? That all makes our services as Ntoroko Health Center 3, and maybe because it contributes what Ntoroko gets to show up or to end up with at national, very poor.
At Gonza Jennifer, an HIV/AIDS patient who has been seated for 6 hours waiting to see the doctor, says the problems of this health center begin with the poor ward, which accommodates patients suffering from all ailments like HIV/AIDS, TB, cholera, among others.
Abarwaire bona urwaire muswija kolera buli kintu azaire bona mbabata mu maternity. Abarwaire titwine bitabu yokubyambira ndekindi abananka hanu twino muzazo obwakuba roho obunafuniamo ebizibu bye noije hanu ntwenda nasi mbagamba nasi akataho buno mwana wa rwaire aho mukazi wenda twine rukukuzaza enju twine enju emuyonka egi abasilimu obundi nitwija titukwendere toko litoija kuija okusanga ba doctor mbagamba titine fasi endi muikara ito habokuba mbatuti twena mu ward tize kufuna mibazi mbatutokea.
Edward Bwambale, the town clerk Kanara, attributes the poor health system to the remoteness of the district, which is hard to reach area, hence keeping the health workers away. He says that there is no decent accommodation for the health workers, and since the area isn't a food-growing district, the cost of living is high, since the food is purchased from neighboring Fort Portal.
The problem is that retaining the health workers is not easy. Like for example, we had got a midwife to assist the one who is there, but because of the nature of the area, she went out. The area is that the nature of the area is that we don't have accommodation at the health unit. Even in the nearby, the houses which people can hire and then stay comfortably are not there. Those which are there are permanent. To a health worker who has come from a good area, a good place which has good accommodation, they find hard time staying in those houses. So she went away, she got another job, I'm told, in Kasese, and we remained with the one who is serving all these people. And again, the other staff, we had recruited a health inspector for the town council who didn't turn up. He came and reported, but on seeing the area, he went away. Likewise, the health assistant whom we had got, in addition to the one whom we have, also came, reported, and went away. The accommodation I've said, it's not there for the staff, more especially the health staff. And again, the distance from the main road, that is Karugutu, to here is 51 kilometers. Sometimes during the rainy season, it becomes impassable. People sleep on the road, vehicles get stuck. So people find it hard to stay in this area.
Okay.
And again, the cost of living. See, this area is a fishing area. There's no agriculture that takes place. Food comes from Fopotro and again from across the lake, Kiwale district. So the cost of living is a bit high.
At Karugutu Health Center 4, the biggest health facility in the district, the situation isn't any different from the rural health facility. The one-ward facility, whose roof was blown off a year ago by wind, renovation has never been completed. The patients are admitted in tents that were donated to the health facility by UNICEF after the storm. There is one ward where children, female patients and pregnant women are all crammed. The ward also serves as a mortuary. When I visited, there was a corpse that had been in the ward from 3 a.m. to 3 p.m. Most patients were in somber as the relatives of the deceased were sobbing and stranded on how to transport the body to Congo. William Tinkasimire, the in-charge, says that as a result of the congestion, some patients with complicated cases are referred to Fort Portal Referral Hospital due to lack of adequate space and manpower.
The complicated cases, we are always referring them to Fort Portal. Complicated cases, we are always referring them to Fort Portal. One, because we don't have either the space and the manpower. But the good thing, we have an ambulance which is functional, although all the time it may not be having the fuel. We go back to the communities also to request to put in their hand those owners of the patients to make sure that we can restore that kind of life. The tents are very hot during the daytime, but we have nothing to do. We are abiding with it. And we thank also UNICEF for having provided, because if we had not provided them, we don't know where we could be accommodating some of these patients.
Simon Kadu Kagwa, the Ntoroko District Health Officer, says that the health facilities are not enough to serve the entire population. The district has a single health center 4, 2 health center 3s, and 2 health center 2s.
We serve a population of close to 100,000. We have health center 4, 2 health center 3s, and 3 health center 2s, which are scattered all over the district. They serve all the administrative units. 6 of the sub-counties in the district do not have any level 3 health facility, and the highest referral facility, the highest level facility in some of those places is the health center 2.
Kagwa says that the inadequate health facilities, coupled with shortage of staff and the poor road network, has affected the district health performance at the national level.
We have the majority of our population living away from the facilities, more than 5 kilometers from the facilities. Currently, our performance is not one of the best on the national mid-table due to a number of factors. This place is challenged with from start establishment. We have few health facilities, as I mentioned, to serve the isolated population and the geographical boundaries of the district. Currently, we stand at DPT3 coverage of around 65%, a little lower than the national coverage. For some of the areas we serve hard to reach in the sense of being mountainous, as I mentioned, the poor road network get flooded and reaching them is hard. Now we also have some islands which we serve, but means of transport are sometimes not available and affect sometimes service delivery. We have 3 health facilities which maternal and child health care services a little comprehensively. That is at least you can deliver in any of these facilities. And they are around more than 35 kilometers from each other. So it makes sometimes attendance as institutional delivery a little lower. Actually, as a Ntoroko, we stand around 15.4% of mothers delivering in our facilities as compared to national average of around 41. Yeah. But significantly, when you look at 6 sub-counties, 6 out of 6 sub-counties without a health center 3. Now, according to the health sector and the plan in the Ministry of Health, each parish should have a health center 2. Now, we are talking at health center 3 where you don't have any health center 3. So, yes, the most vulnerable people in our societies, they are somewhat disabled, but those who impact much on the indicator performance and the Millennium Development Goals are children and women. In health center 3 is supposed to be a first point of contact for maternity services as well as health services. So lacking health center 3s in some of these places is one of the big issues affecting performance. We are still receiving fairly little allocation for factor development, and that's why we can't take on big projects. We are hoping that next financial year we shall be able to start construction of an inpatient ward here, which is a project which will take us to 3 or 4 years.
Despite the few health facilities, not all is gloomy. Kadu says that in 2010, when the district started, the staff percentage was at 36%, but today it is at 72%, following interventions by the village health teams, UNICEF, Baylor, World Vision, among others. He also says that they have started prioritizing accommodation for the health workers, which will prevent them from abandoning the health facilities. The Chief Administrative Officer, Ashaba Alan, says the district is doing poorly in critical staff cadres, where there is only one doctor who is the DHO doing administrative work and only one doing clinical work recruited by Baylor, but lacking other 2 doctors.
When we started our human resource, the staffing levels was at 35%, and right now we are at 72%. We have recruited through the support Ministry of Health. So the staff are now there. We have 72% in terms of staffing. Yes, when you talk of 72, the staffing for health has those that are critical and those that are support. Meaning that you have the cadres that do support work, like the enrolled nurses, you have the porters, you have the enrolled nurses, but there are those critical like doctors and senior clinical officers. So we are doing bad in terms of the critical staff. Those are the doctors. We have one who is administrative, who is the acting DHO, and we have another one who is doing the clinical work. But this one was recruited under Baylor. Under Baylor, as an NGO, supported us to recruit that doctor who is based at Karugut. So we miss another 2 doctors. Now the challenge we have one health center for which is Karugut, where we have only one ward. The ward which serves as a maternity ward, it admits children, pediatric ward, it's admitting everybody in one ward. So you find that the number of patients that we get cannot really fit in that ward. So we have a challenge of the infrastructure in terms of the ward facilities. We don't have enough facilities to admit staff.
He also attributes the poor health service to dispersed population, where people have to travel long distances for health services, citing sub-counties like Butungama and Itojo, where there is no single health facility, yet they are some of the hard-to-reach areas in the district.
Our communities are scattered. It's a hard-to-reach area. There are places where people don't settle. They're just farmland. So you find there is a very big gap between where the facility is located and where the community is. So the people have to travel long distances. to reach health facilities. So that's why you may need like Butungama, the sub-county, but there's no health facility, not even a health center too. Itojo here, which is in Karugutu, as a sub-county, does not have a health facility. And those are some of the hard-to-reach areas. So we really need to, if we had funds, we would be able to put up these facilities. So the issue of budget comes in as a challenge. Because as a district, we get 119 million per year for development. And development fund, that's why we get money to build the staff houses, to build the wards. So those ones, with 119 million, you can only afford one structure. You cannot even build a full ward, because a full ward, as per standards of Ministry of Health, is about 350 million. So it will need about 3 years to have one ward put in place, which is not very practical.
A report compiled by the Coalition of Civil Society Organizations on Health in the Rwenzori region indicates that unqualified health workers operate in major health facilities in the district. The report follows complaints received by the civil society organizations from residents who accused some of the health centers of not providing adequate treatment. The report also reveals that relatives of some medical workers and casual laborers in the district have also taken to administering treatment to patients in health facilities in the district. According to the report, some of the health center workers are not trained to treat people and have no idea about the medicine they prescribe to patients. Under the Local Government Act, districts and municipal councils are responsible for medical and health services, including hospitals, except regional referral hospitals, all health centers, maternal and child health services, communicable disease control, ambulance services, vector control, environmental sanitation, health education, quality monitoring of water supplies, supervision and monitoring of private sector health services, immunization campaigns, health promotion, reproductive health, including family planning, among others. Despite the huge health mandate vested with local governments, only 27% of the health sector budget, equivalent to Uganda shillings 41.185 billion, is appropriated to 137 local governments, 56 general hospitals, 61 PNFP hospitals, and 4,205 local level health units. 40% of the health budget is spent at the center. For the last 10 years, Uganda Parliament and civil society organizations have consistently advocated for better health care delivery. However, the committee observed that the proposed expenditure plans for the financial year 2013-2014 were not geared towards PHC as priority. The committee recommends that more funds and energy be expended in primary health care to facilitate the local governments and lower health facilities, including PNFPs, to deliver on their health-related mandates. This report is compiled by Betty MUJUNGU, facilitated by African Center for Media Excellency, and supported by Democratic Governance Fund.